but we're gonna look at kind of 4 variables, and I'm gonna use 3 tools very quickly to give you an idea of what that looks like. So I'm gonna get you to stand and it's your left shoulder, correct? Okay, face that way for me. I want you to put your hand here, and I'm gonna demonstrate what I want you to do. I want you to take your hand like this, and I want you to press directly overhead. Okay, not bad. So I deal with overhead athletes, I deal with javelin throwers, baseball players, but my patients, doesn't matter who it is, we look at their overhead competency. Can they get here? Can they get to a position where the joint is in a really clear position in the capsule? Is it centrated? When you centrate a joint, the length-tension relationship is optimal and the input to the nervous system is optimal. So we want to clean this up. So what I'm going to do is just go again, push up, and then back down. There's 4 reasons that someone's going to lack overhead competency or overhead mobility. Number 1, is there a change in the actual soft tissue structures in the balance? The shoulder's based on 2 fundamental, the 3, but the 2 fundamental force coupling mechanisms are essentially the deltoid cuff coupling. Essentially, what the deltoid does is outward and upward, cuff inward and downward. But we know seldom does the cuff provide the necessary symmetry in that joint. So we're going to treat these structures. We're going to treat them with 3 different tools to see if we can clean up some of the soft tissue restriction. It's a motor control problem. There's also an anterior-posterior coupling mechanism. And again, if you can face them quickly, just drop your hands at your side. Okay, you can see, if you look at the front, if you see his 3rd knuckle, we know we have a problem. Just look straight ahead. And his default is this. He is a flexion prejudiced person. He's in a flex position. So we would do a ton of work on thoracic extension. So the 4 variables are this. Number 1, is there a change in the actual coupling mechanism of the shoulder? Are these muscles firing in a way that's symmetrical in centrating the joint? Number 1. Number 2, thoracic extension. And generally what happens is that you can see there's a kyphotic frame here. And if I was to test him, guaranteed as he pushes overhead, a lot of the extension or a lot of what he gets in the shoulder is a result of lumbar extension. Number 3, scapula. The scapula, when we have problems with how the scapula functions, whether we have the appropriate downward and upward rotation of the scapula, it's a motor control problem. And this is where exercise becomes important. Getting the scapula to function effectively so that the scapula is on the rib cage and gliding appropriately is in every way essential to shoulder function. As goes the shoulder, so does the scapula. And the problem is that if this joint isn't centrated and the humeral head doesn't glide in an inferior direction, as I come into abduction, for every 2 degrees of abduction, there's a degree of upward rotation of the scapula. And if we lack that, we're going to lose centration. We lose inferior glide of the humeral head. It drags the scapula with it, and it pins the upper structures, an impingement presentation. So that's number 3. And then the last one, which I think is essential, is lumbopelvic control. This feeds this. If someone has good lumbopelvic control, we know that the shoulder is going to be more efficient and mobile. So every patient with shoulder problems, lumbopelvic control drills. I give everybody this. So we're going to use 3 different mechanisms around which we're going to kind of start to work on this. You good?